Good morning, everyone. And this is actually the first time Mike and I have seen each other virtually in a while. We spend a lot of time in person together lately. But I am Joyce Agne, and I am from the Center for Innovative Practices, Child and Adolescent Behavioral Health Center of Excellence here at Case Western Reserve University. And we're going to talk today about the importance of safety planning with youth and families. I like to make this presentation a lot about how we want to steer clear of those kind of standard, maybe cookie cutter kind of safety plans when working with youth and families, and how to make them very individualized to the needs of the youth and families that we're working with. So, to start us off, just some ideas around why we need effective safety plans. So, obviously safety is at the top of our list when working not only in home based, but for the clinician going in and doing this work for the client and family safety, the safety of others in the community, but also largely focusing on how do we use safety plans to prevent those unnecessary out of home placements, or even use them to reduce the length of stay in out of home placement when maybe placement is necessary. But this can be that collaborative piece that we bring in as kind of, maybe discharge planning from an out of home placement to say, we've been working with this family. We have really good plans in place. The family feels empowered enough to bring the youth home, maybe sooner than they would have without an effective safety plan in place. We also are empowering the caregivers to really be able to manage those challenges, not only quickly in the moment as things might escalate, but long term. So after we may close with a family, I know specifically myself, like I'm an IHBT consultant, so I work with a lot of intensive home-based teams, and they're involved for about 3 to 6 months on average. And in the long term, we want them to have a plan that follows them and is sustainable for the family. And we can do a really good job of that when we have effective safety plans that grow and change with the family's needs. Some of the barriers that I see at times with effective safety planning is sometimes around insufficient information during the assessment. This is why when we make a safety plan at times, it is during that assessment process. And that's kind of maybe a standard for agencies, or like a requirement that we do along with a mental health assessment, and diagnosing someone. But then that safety plan may never change. And that's where we want to look even deeper into, yes, we want to have something that the family can walk away with from that first session, but this should really be kind of a first draft based on the information we gathered during the assessment. I think we all know that at times we're not getting all of the information in that first session. It's very likely that a family doesn't want to open up and tell you their entire life story and things that could be going on because they just met you. So, not allowing that first draft to be the only draft that ever exists with a family. There can also be difficulty in creating these individualized plans. So, especially if you do very niche work with a certain population, it can feel like, oh, I've seen this kiddo before. I've seen these types of problems. These interventions work for this. Always recognizing that every family is going to come in with their own needs, their own strengths that can be utilized into a safety plan. So wanting to make sure we're truly making each plan individualized to their needs and strengths. Another thing is limited natural support. So often we are talking about who can help out in the plan, who can be responsible for this step in the plan. If there's limited natural supports and we're talking with, maybe a single parent who is like, I do this all on my own, there isn't anyone else who can help me. It's how do we help that caregiver explore maybe some more creative options? So is there a neighbor that they trust, or is there a neighbor we can, really empower them to build a relationship with? So it might mean when someone escalates in the home, if there's other children in the home or other people in the home, could they go to the neighbor's house? It could mean, where is our, safe spot outside to get, again, remove individuals from the situation and allow that parent to then, focus on what is happening, knowing that the other individuals in the home know this place to go. So even when there's limited natural supports, we can still really help families in building those natural supports in some more creative ways as well. Lack of understanding or engagement from the client or family. So I think this comes into play, especially in the beginning of treatment, but also it's being able to recognize as the clinician when a family is engaged versus is a family truly aligned with the plans that we're making. And the way that we make sure they're truly aligned with the plans that we're making is that we help build this emotional safety for them to come to us and, have those open, transparent discussions, but also, do they understand the steps of the plan? Did they collaboratively help create the plan with you? That's a lot of the times where we see the fall off in alignment with the plans, is that they agreed verbally, yes, we can do this plan works, but did they really help create it step by step? So that's a lot about being less directive, being more empowering in the creation of any type of plan, but especially safety plans, because these are very high, emotionally reactive moments where we need to make sure that they feel comfortable utilizing the interventions that we are, teaching them to use or, putting into a plan. Which also kind of goes into sometimes clinician skill set or understanding of importance of a safety plan. So it's kind of just a mindset shift around the safety plan not being that document that goes into the chart or into the file and we have it, it's, we check the box, but how is this really a plan that helps the family to mitigate the risks and works with their strengths to keep that youth in the home without utilizing, police intervention, without utilizing hospital admission each time, there's potential escalation in the home. So I've kind of alluded to, we want to regularly monitor and update the plan. So always making sure that we're checking in on this plan. Again, I work in intensive home base, but thinking about the youth that I'm sure all of you work with in your areas of work as well, we're working with high needs youth and families. So we can check in weekly. And even if it's just, how is the safety plan going? Any concerns? Is there anything that happened in this past week where you feel like you didn't feel comfortable using a certain intervention, or you don't feel like it's the best intervention for the scenario that played out? It could just be checking in again verbally, and they say, no, everything's been going really well. The plan's working great. Okay, great. We always love, to hear that. But if we're not asking and checking in, we're also not monitoring that plan. Which I also think speaks to documenting in your notes, in your discussions with families, clinician engage the family in a discussion around previously developed safety plan. Families stated XYZ, plan's going well, this didn't work, safety plan was updated, making sure you're documenting that along the journey as well. So in thinking about how we can develop a really clear plan for what needs to take place in a safety plan, we can use things like sequencing and really conceptualizing the behavior even further. So doing some functional analysis of the behavior to determine, where is the youth getting escalated? What are the triggers? How do we have a plan for supervision and monitoring? Do we have a plan for searches? Thinking about like when they return home from school, are we searching, at least checking a book bag to see if they brought anything home from school or to see what they're taking to school? Again, things that we can do to prevent, be more preventative in risk. And then what is the plan to relocate or secure any of those potentially harmful items? Something I also hear at times is the difficulty in engaging families in safety planning because potentially they have done this in the past and maybe they have the mindset that this is just that document we have to do, or, we have one with our Ohio Rise Care Coordinator. Now, how is this one going to be any different? We already have this one. We don't need another one. But really, it can just be a very engaging process in completing a safety plan. We get a lot of information in working through a safety plan with the family. There can be a lot of intergenerational trauma and some systemic distrust. So, how do we address that in the ways that we're engaging families when we do safety plans? If there's any conflicting family dynamics or some power struggles or different structures of power in the family where maybe the youth has more power than the caregivers, and how do we address that in safety plans as well? It can also just help us bring some of that out, bring it to the surface to know that we need to address this. Also, any cognitive limitations or severe mental health symptoms that are maybe triggered in those moments when things are escalated. Legal and ethical considerations. So the fear of mandated reporting. If I tell you things, are you going to have to report this? Is this going to mean that then Children's Services is coming to knock at my door? So one of the ways that we really help our engagement in safety planning is through creating that emotional safety and having a plan can be really helpful for them to know, okay, when this happens, do this. And that can be, again, it's not directive. We want to collaboratively build that plan with the family, but it's empowering for them to have that and have as many copies as they need. Again, changing it as often as necessary. So some of the strategies around building engagement and alignment with safety planning, talking about it from that first session or from that first meeting. Even when you call to schedule the first appointment or to schedule the first meeting, we're generally doing some safety planning aspects and even in modeling, is there anywhere, especially in home base, like, is there a certain place I should park? Do you have any, anything I should know about before I come to your home? A lot of agencies have like very specific safety checklists that can be helpful questions to ask when you call a family to schedule. Do you have dogs that I should be aware of, or any animals or anything that I should be aware of before I get to your house? Same as creating emotional safety by letting them know, when I get there, this is what I will do. I'll come to the front door and knock, or do you have a preference of where I come to the door, what door I come to? And then, we'll sit down and we'll meet, and this is what we're going to do in that first session. When we involve them in that decision-making process and allow, again, asking those questions to give them the agency over how things go, we're really going to help engagement and alignment as well. Starting with safety basics. So like when we are introducing safety planning, explain the process to them, explain why we're asking the questions, what questions we're going to be asking, discuss their role in safety planning. Like I said earlier, they have the most important role because they are going to be the ones that live this day in and day out. We want them to know when they should call us and when, they should seek help from, emergency services if they need to call 911. Like what level does it need to be at before they make that decision? We always want their safety to be at the top of the list. So if in doubt, they always have that option. But we want to work to really coach them in recognizing that you can do these things without, maybe calling the police or engaging outside more, formal systems. Always expressing empathy while we're safety planning, because sometimes safety planning does include a lot of daily inconveniences, like locking up all the sharps, locking up the medications, keeping things in their car that maybe, they don't want to live that way forever. And expressing that these plans are going to help us determine, how to best work with crisis situations. But for now, in this moment, like, this is the best way to keep your child safe, your family safe. We want to work together also to be able to not have you have to deal with those daily inconveniences, because just recognizing that they are inconvenient can mean a lot to a family. I already touched a little bit on this, but the benefits of safety planning, really how we're helping them to have clear guidelines during emergency situations. We want them to have that sense of security and confidence in being able to manage these scenarios on their own. It's also going to improve their quality of life. And that's what we want. We don't want them feeling like anytime something happens, they don't have the power to be the change agent themselves, because that's what we're really here to do and empower them to do, is that they are able to make significant change for their child, more so than outsiders that can come in and maybe yield power to have some influence. So those external factors, like, well, if you don't do this, if you don't calm down, we have to take you to the hospital, we have to take you to juvenile detention, whatever the scenario may be. Parents having that change agency is so much more empowering than having them turn to those outside external providers. So quickly, I just want to kind of walk through like the step-by-step process that I work through with clinicians around creating a safety plan. So we've already kind of talked about step one, the assessment, the identification of what the actual risk behaviors are, the escalation patterns, the crisis triggers. We're getting a lot of this information in the assessment. We want to make sure that we involve the client and the family in this step, so they are also aware that we are, helping them to determine what those triggers are, what those patterns are, and this is why we're doing this. So some of the ways we can identify triggers is through, behavioral observations, just being there in the home, asking others, their behavioral observations, communication patterns, any environmental shifts. Also recognizing patterns using, some timeline analysis or feedback from the family or the school or other partners that may work with the youth, but also looking at some historical trends. And that's why I think sequencing is so helpful. When we sequence out, a crisis event from start to finish, we can see a lot of this play out and help the family recognize those patterns and triggers as well. Safety tours of the house are also a really important part of assessment. Crisis functional analysis, I mentioned this earlier as well. After that assessment piece, then we're really moving into, the development of the safety plan. So creating that individualized safety plan. That plan needs to be clear, it needs to be actionable, and it needs to be really easy to understand. Because think about when emotions are high, you need something that can be quickly understood and the action steps are easy to follow. We want to make sure that we also include preventative strategies in that plan. So we're not only addressing aggression or harm when it happens, but before it happens. That way they can, caregivers can recognize it in that trigger stage to hopefully change the sequence and decrease the chance that it escalates into, a higher needs crisis. Also using behavioral contracts as kind of a complement to the safety plan to work to apply consequences and rewards really consistently for the lack of aggressive behaviors. Step 3, we talked about, how do we incorporate natural supports? How do we help them even identify who those natural supports are in their life? If they're saying, well, it's just me, how can we creatively come up with some other support systems for them or help them identify where they may be able to make relationships? Step 4 is really around crisis stabilization and de-escalation strategies. So not only teaching those to the caregivers or anyone else who's involved in the plan, but also to the youth. And then step 5, implementation of the safety plan. Make sure we role play with the family before we give them this plan and say, well, here's all the steps. Let's really work through it with them in real time to see like how they can practice, safety plan drills, things like that. Step 6, document and distribute. So essentially, whoever needs a copy, give the family more than one copy and make sure you have obviously documented this in your records. And then 7, really important, monitoring, reviewing, and updating that plan as often as necessary. Make sure when it does get updated, anyone else on your team or any other relevant partners get a copy of that updated plan as well. Okay. And I think that is all for safety plans. So thank you everybody for your attention time today.